Good afternoon. At the outset, I would like to thank the organizers, uh, Dr. Chatterjee, Dr. Arijit, Dr. Ganguly for kind invitation and very warm welcome that the organizers have given here. And so I'm going to talk about the role of neuromodulation, especially the remote electrical neuromodulation in migraine. And Sir Dr. Devashish in his oration had described how the headache medicine has evolved from the ergots to the monoclonal antibodies and neuromodulation. So neuromodulation has come up in a big way. And this is a very exciting field because it provides more opportunities, as Sir told, more choices not only to the patients but also to the treating physicians. So to manage headaches better with minimal side effects. So uh, first, I would focus on why do we need the beyond the pill approach, and why do we need the neuromodulation? So this has already been discussed how the headache field has evolved. And neuromodulation basically came up in the early 2010s when the first approved device was available, the TMS device, and following which there were other devices which were made available. There were trials which they found that these are effective for acute as well as for preventive medication for management of migraine. And unfortunately, many of these devices are not available in India. The only device currently available is the remote electrical neuromodulation device, which came up in 2019. And then since then, there have been several studies which have evaluated the effectiveness of this device in acute as well as preventive management. So initially in the early part, as Sir told, most of the drugs, they were discovered by chance. Ergots, even the preventive medications, they were discovered by chance. We were using repurposed drugs until triptans came. But now, recognizing the use of CGRP and the role of the trigeminal cervical complex, the thalamus, the role of central sensitization in migraine migraine pain propagation, we have come to know that neuromodulation can be a very helpful device for management of migraine. So this acts basically on the not only on the trigeminal cervical complex and the brainstem pathways for pain. So neuromodulation is basically defined as an alteration of nerve activity through a targeted delivery of a stimulus such as an electrical stimulation or a chemical agent to specific neurological sites in the body. So for migraine we have non-invasive neuromodulation, and for refractory migraines which are not responding to anything, there are options for invasive neuromodulation in the form of occipital nerve stimulation, deep brain stimulation, or sphenopalatine nerve stimulation. But that is something which is very niche and is only used in patients who are very refractory to other kinds of all kinds of management. So basically the non-invasive neuromodulation can be either central, which is the transcranial magnetic stimulator, and then the peripheral, where we are either stimulating the nerves which are converging on the trigeminal cervical complex, such as the trigeminal nerve stimulation, the Kefali device, and the occipital and trigeminal nerve stimulation, the Relivion device. Then we are also using the vagus nerve stimulation to decrease the pain. And finally, remote electrical neuromodulation. This is a device which is available in India, and there has been a very good experience with this device even in India. So when we talk about treatment of migraine, there is an acute migraine management and preventive migraine management, and there has been a barrier between the two. So we give either acute medication for the abortive treatment of migraine, and then we are using preventive medication. So now these neuromodulation devices and the G-bands, they are breaking the wall between the acute and the preventive medication. So here we have a device or a medication such as G-band, which works not only for acute attacks but also for the preventive management. And when the patient is using the medications acutely, the effect of the preventive effect also kicks in, and therefore the headache days continue to decrease. So currently, because although G-bands are now available, but they're in India, but their currently they are approved only for acute medication use. They are not approved for preventive use. So currently the only available option which can help both acutely and for preventive management is the remote electrical neuromodulation device or the neuromodulation devices. So how do we use this device? This is basically worn on the upper arm, and this comes along with an app which is built into the mobile phone. Both the Android and iOS versions of that have the app, and then the patient uses the app to start the current stimulation, increase the stimulation to a strong but non-painful stimulus. This which is to be taken started as soon as the headache begins, before it becomes severe, so as to prevent the central sensitization that occurs. And this can be used for acute attacks, and for preventive management every other day this can be used. So how does this REN work? So this is basically what a remote electrical neuromodulation is doing is it stimulates the A delta and the C type of sensory fibers, which activates these fibers go up to the periaqueductal gray matter. They go up to the periaqueductal gray matter, and then they modulate the pain mechanism. So there are descending inhibitory fibers which go to the substantia reticularis dorsalis, locus coeruleus, and rostral ventral medulla. And then these basically inhibit the pain mechanism occurring through the trigeminal cervical complex. Ultimately, we are modulating the trigeminal cervical complex, which plays a very important role in the pathophysiology of migraine pain. So basically, this is a proprietary signal which stimulates these A delta and C fibers, which has a frequency of 100 to 120 hertz, which reduces the risk of habituation or desensitization of sensory fibers, and the width is around 400 microsecond, which balances the efficacy and the tolerability. So by this mechanism, basically there is a global reduction in pain which helps in migraine. So there is another thing is why this using the upper arm. So first of all, it's very convenient. Patients can wear this device. They can go on with their work while they are wearing this device and using it. Secondly, there is a lower concentration of motor neurons superficially here, and the muscle layer is thin, and the muscle and fat layer is thin. So all these factors make it important that we use it at the upper arm. The device basically uses the upper arm, and it is also easy to operate for everyone. So there are two important factors when we are using this device which should be known, and if not properly advised, this could be one of the reasons for the loss of efficacy or decreased efficacy. So the first thing is that the current should be strong but not painful. So in the app there is a percentage of the current. It initially starts at 12%. The patient then increases the current according to through the app till a point where the current is strong but it is not painful. So it will be individualized and different for every person, and at 40 milliamperes it's 100%. So there have been studies in India, this has been studied in real world data, and most of the patients have, depending upon the age and gender, basically the current strength remains around 35 to 45%. So it will be individually variable. But the rule of the thumb is that whenever you are prescribing, you should ask the patient to increase the current strength to a strong but non-painful stimulus. So whenever it becomes painful, just decrease that strength to a point where it is no more painful. The other thing is that, like all medications, when we advise acute medications, even then we ask the patient to take it as soon as the headache starts, before it becomes severe. Because once the headache becomes severe, then the central sensitization sets in, and in these cases, neither the medications, most of the medications, and neither these devices tend to work better. So the efficacy decreases. So, and again, the patients it should be emphasized, whenever they are using it for an acute abortive attack, they should use it as soon as possible, preferably within 15 to 30 minutes of onset of headache. So these are the two important points which patients should keep in mind. Physicians should clearly state that early use within 1 hour, and a strong but non-painful stimulus which should be individualized. So what are the patient groups where we can use this remote electrical neuromodulation device? So basically this is a patient who is treatment resistant chronic migraine with medication overuse headache. So she has 25 plus headache days per month for more than 3 months, as medication overuse is been taking triptans for 10 plus days per month and NSAIDs for another 10 days. So has failed multiple medication classes including topiramate, beta blockers, valproate, and even botulinum toxin. Has significant functional disability with a MIDA score of 78 and has comorbid anxiety and mild depression. So, what options do we have for optimization of treatment? So, this patient has chronic migraine with medication overuse headache. So, currently, what options we have? We can first of all, we can shift her to a monoclonal antibody. Erinumab is available. We can use a GPANT for acute treatment. The problem is GPANT is also very expensive and currently only available for acute treatment use. Erinumab again is available, but the patients may not like to inject. So here is where remote electrical neuromodulation comes into play. It's a safe approach which not only treats the acute attacks but also prevents migraine, and most importantly, there is no risk of overuse, medication overuse headache with this device. And there is no interactions, it's safe. Patients who don't want more pills or more injections, this is a good option for these patients. So, what is the data for this? So, there have been several studies here which have found that with the REN device, Nerivio, there is a sustained pain relief of almost 66% with a therapeutic gain of around 30%. Pain freedom is around 37% and a therapeutic gain of around again 18%. And it also has a very good response for the most bothersome symptom relief and freedom from most bothersome symptom to the tune of around 46%. When we use it for a preventive medication as a preventive treatment, then there is a decrease of almost 4 monthly headache days and almost 3.8 moderate to severe headache days. And the effect is consistent if we are using a prophylactic drug or if we are not using a prophylactic drug. So in both cases, this helps for acute as well as preventive medication. And the effect is similar in episodic as well as chronic migraine. And it has been found that when we are using remote electrical neuromodulation, the acute medication days per month are also decreasing significantly as compared to the sham device. And so there could be a difference in whether there is a difference between patients who have migraine with aura or without aura. So again, this device works very well in patients who have migraine with aura, similar to patients who have migraine without aura. So in all these migraine groups, this device has got excellent results, almost similar to what we get with other acute oral medications and preventive medications. And although it is advisable that it should be used as early as possible, even when given around 1 hour into the headache, there has been good pain relief and pain freedom, but still it is always advisable that we tell the patient to take it as soon as possible before the headache becomes severe. So for this patient, REN was remote electrical neuromodulation was given as an option for the treatment. It was decided that for mild to moderate attacks, REN with a strong but non-painful stimulus should be used. But for severe attacks and for rescue therapy, a triptan plus antiemetic was advised. At the same time, she was advised to use it as a prophylactic treatment also. So she was taking it every alternate day and using it whenever she had headaches. And the prophylactics were optimized because of the comorbid anxiety and depression. Amitriptyline was added along with lifestyle modification, and there was a significant improvement in the headache with decrease in MIDA scores, headache days, and the patient felt much better. So currently in Nerivio, REN device is the only approved treatment option in India which offers dual benefits in migraine care. So it not only provides acute abortive treatment but also the preventive medication, preventive treatment part. And this would be a very good factor that to decide for management in patients with high frequency and episodic migraine and chronic migraine, and those patients who have medication overuse headache, because it will help in these, specifically help more in these patients. And as I told earlier, even if the patients are not using it as a preventive medication, but when they are repeatedly using it as an acute medication, even then it has been seen that in these patients, the number of headache days and migraine days per month continue to decrease with continued usage of this device. So there has now been tolerability data in real world studies also, and this may be a particularly useful device for children and adolescents where we have limited options for treatment of migraine. and in adults with particularly with pregnancy and breastfeeding patients, where again we have a limited options. So this is currently approved in India for patients more than 12 years of age, but FDA has recently approved it for even for more than 8 years of age. For India, it's still 12 years of age, but probably off-label we can use in 8 to 12 years of age. And as I told, it is very useful in pregnancy and breastfeeding. We have very limited options for acute medication management. Just mainly paracetamol, triptans can be used, but obviously there is a fear that they may cause some problems. So the safety data for pregnancy and breastfeeding for this device is very encouraging, and there are literally no significant side effects compared to the placebo. And again, the key points for patient education is that we should ask the patient to use on the device on the upper part, lateral side of the upper arm. They should increase the intensity levels until it is strong but not painful. They should use it as soon as possible within 15 to 20 minutes. This increases efficacy. Whenever a patient reports that this device is not efficacious, we should double check whether they are using it properly or not. For preventive treatment, they can use Nerivio every other day, even if there is no migraine attack during that day. And in case session is taken during that day to abort the attack, that will be counted as a preventive medication. So, if they have taken it for an acute attack, they need not take it again as a preventive attack management. And basically, it is a single approach which can safely treat as well as prevent migraine. Probably we are heading towards that paradigm where we have a single drug or a device which can both help in acute abortive medication as well as in preventive medication. But it's important that we explain these to the use of the device to the patient, and more importantly, what they expect from this device, and train them properly and discuss the treatment protocol properly. And most importantly, always track the outcome with the use of a headache diary and treatment of questionnaires like the migraine treatment optimization questionnaire for the acute attacks, and should ask the patient to maintain a headache diary so that we can follow up and know how the patient is behaving with the use of these devices. Thank you.
So your personal experience?
So frankly, I have limited experience. This is an expensive device. So 50-50. Two of the patients improved, two didn't improve. But I think probably what I did wrong was I did not call them and tell them how to use this device properly. Dr. Devashish has more experience with this. So
Just tell us personal.
Yeah, so I think whenever something new comes up, we look up with a lot of expectations, but only the things which stand the test of time, and still remain efficacious, that persist. So that is both for drugs as well as for neuromodulation. So I think the advantages here is this, that it is very simple to use. Patients can be well instructed, and it is even for the uneducated patients, they can understand because they are now using, most of them are using smartphones. So, and it is very useful for children and adolescents, and for pregnancy, during pregnancy. So these are the conditions where I've been, keen to use this treatment. My experience with the acute phase is better. That the acute treatment, people, especially it decreases the intake of the acute medications. Like people who are having MOH, it is very difficult for them to stop the drugs altogether. But once you give it in addition, then they start taking less and less of acute medication. For the prophylactic treatment, I would say that the response is around 40 to 50%. So I have got about 15 or so patients, national as well as international. So they are, having this kind of a response. Also, I think that it is important because the entire cartridge which is there, that is meant for about 18 stimulations per month. So after that they have to, so some people initially start with, they get the benefit, some benefit, but when they are asked to again refill after 1 month, they say, "Nahi, doctor, utna to acha nahi laga." The cost consideration comes up. So it is slightly then get biased by that. But now they are coming with the. They also have a scheme in which I think you can try it for 1 month. If the patient does not respond, then the money is returned. That scheme is there or not, I don't know still, but there was a scheme like that. And I think I don't know that whether that scheme still exists.
That was present in 50 days back. They told.
Yeah. So and then the another thing is that they are now coming with another device in which it is a longer this thing which is called what infinity occur? Eternity.
Infinity.
Infinity.
Yes.
So they are going to infinity. So that kind of thing that when you don't have to change this, and obviously that will be priced higher, I think, than that.
Bit lower, sir.
Bit-
Not yet decided.
Not yet decided. So I think that is to be launched. So they have come up with that. So that will be again a useful thing. And the fourth thing is that some people this will be contraindicated with any kind of implants or pacemaker. Those patients are out of this, so you can't give it to them. And finally, I think many patients are having kind of two types of patients are there. There's somebody like this kind of treatment, and the other group doesn't like at all to have something padded up on their arms. So I think what I personally told them also that I see a future in the acute treatment group and possibly to a smaller extent to the preventive treatment group. So probably because now people would like to take either a MAB or a GPANT for prevention. I mean that is going to come. That is going to come in India in another 4-5 years. So I think, but nevertheless, I will again tell you that they have sold 5,000 units in India so far, more than 5,000 units so far in India, if I know it correctly, and I think that more are coming. So I think there is a general general interest, and people want something which can replace the drugs.
I have a comment. The problem with this device is if you use for a preventive one, after 36 days, the 18 cycle gets over, and then you have to again refill the drug, which adds to the cost of the therapy. Is there any way out to prolong these 18 days as of now? No, or it is just.
If there is, the patient is on episodic migraine, he has 5 to 8 days of migraine.
Yeah.
So they can use only as an acute medication.
No, acute is fine. I'm asking for the
That
preventive.
actually, what they have shown is that even if you are using only sparingly for acute attacks, the overall the headache days continue to decrease. So
No, Kaushik, the point is that 18 days kept like this, that the 15 days alternate day for 1 month and 3 additional days as a cover up for any acute attack that happens in between. So that was the original plan for them, right? But actually that has failed. That's why they are coming up with this continuous eternity, this thing. Because that's a difficult thing to achieve, actually. Because migraine is such an unpredictable and fluctuant disease. You don't know when the stress factors and other, environmental factors are high, the patient will keep on having the headaches. And when there is low, the patient may have a long term, much better.
typically, I think the patient with chronic migraine will obviously be on some other medication also.
No, that's what they are saying, that it can be given without medication, but I think the role will remain complementary.
Thank you, everyone.